All right, so let's start with this. And like I said, I'll give you the history, show you the morphology, and then you tell me what you think, and just put your comments on the chat, and we'll try and go through those as they come up. Okay. I may not be able to address every comment or every question, but I'll try my best. So this is what I think is a nice case to start with, which is where we left off really in my last slide seminar. And it's a 52-year-old woman with an abdominal wall tumor. And here on low power, and just to always share the advantages of having scanned slides, is that this low power you cannot really see on a glass slide, but the advantages of having it scanned, you can see it's very well circumscribed, dare I say encapsulated as well. And there are two sections put into this block, so we'll examine that. So she's 52, woman, and this is an abdominal wall tumor. Do I have a size for you? I don't have a size, but I would imagine it was about 2 to 3 centimeters, so it wasn't that big. And I received this from one of my colleagues in GY, and I'm thankful for sharing the case with me. So here we go. Let's look at the morphology. Like I said, very well circumscribed, and comprising predominantly spindle cells, as you can see, just to give you a higher power of that. I try not to give you too much of morphology or morphological interpretations, A, not to lead you, and B, not to mislead you. But these nuclei look pretty uniform. I can share with you they have vesicular chromatin. Some of them have nucleoli. And as you can see on medium power, there's some sort of fascicular growth pattern. Here it's the same fascicle, but cut across end on, so they appear round rather than spindled. There are some vessels again here. I'll come back to that area there as well. I just want to show you other areas before getting down to the areas of question. Here are some areas here. This sometimes is interpreted as being myxoid, and you can see this is a vessel, and that's the white of the vessel with no tissue, and that is also almost white. That's water. That's just edema. Okay, so not to confuse myxoid material with edema. And then continuing into the center of the tumor, you can appreciate these spindle cells looking pretty uniform. I can add that there are no mitotic figures. And then I want to show you two other features. One is, on low power, you may have noticed these cystic structures here. And I want to take you down to examine this. And you can see that it's lined by epithelium. All right. And those of you who are focusing much better than I do, you probably appreciate some of this looks ciliated as well. The epithelium is cuboidal, sort of medium-sized height, but nice round uniform nuclei, no mitotic figures, and you can see these ciliated structures throughout as well. So that's the second component. And the third component I want to share with you here is, so the spindle cells is one, fascicular, looking very pink, uniform, no mitotic activity. And the second are these cystic structures. I'll share with you, they do look epithelial, and they're epithelial cystic structures. But the third feature I want to share with you are these cells here. And here's a nice area. There was one area that was in the subcapsule area, but we don't have to go back to that. But just to show you these atypical looking cells. I'm using the word atypia because I'm trying not to put you in any particular frame of mind. So you use your own discretion as to what you think of these nuclei. Some of them look dark, and some of them may even have intranuclear inclusions. But again, no mitotic activity in these. Some of them are multinucleated. And here again, just to show you these cells. Okay, so these are scattered in and amongst, in between the spindle cells. Here again, going back to spindle cells, this long fascicular pattern that you can see, and they crisscross throughout the tumor as well. The vessels are sort of nondescript, but some of you may like to look at the vessels showing almost like a staghorn vasculature. But again, not to put you into any particular diagnostic area, but you can see these staghorn vasculatures as well. Here again, more bizarre cells. Oh, there's a beautiful internuclear inclusion there. And these multinucleated cells. I've pretty much shown you all the features I have to show you. So I've already have one suggestion of a stump. I've got solitary fibrous tumor. I've got just leiomyoma, endosalpingiosis. And I even have FD, that's fumarate hydratase leiomyoma, stump, SFT. These answers come pretty quickly, so I'm trying to write them down as I go so I can address all of them. There's GIST and there's leiomyoma with endosalpingiosis. There's also ESS, another fumarate hydratase deficient leiomyoma, and then a synovial sarcoma biphasic. That's pretty decent. That's very decent. So synovial sarcoma, let's start. I'm just starting at the bottom, then not literally picking on anybody, but just starting at the bottom and moving upwards. Oh, there's a schwannoma that just appeared as well. So we've got smooth muscle, we've got nerve sheath, we've got synovial, we've got GIST. That's a good start. That's a good start, and it leads itself to a panel of markers that one would use. And for schwannoma, obviously, most of you know. Again, my favorite is to start with SOX10 and S100. For smooth muscle, we've got two smooth muscles. We've got a FH deficient leiomyoma and we've got a leiomyoma. So for that, I would like to start with SMA and Desmond. And then there's GIST as well. So whenever there's GIST, I usually just resort to all three markers. I mean, DOG1, CKIT or CD117. And then I like to do CD34, which is positive in about 70% of GISTs. I like that to back me up as well. There is a solitary fibrous tumor, so CD34 comes in there as well. So we're covering two tumors in our differential diagnosis. And if you're thinking of SFT, and if you do have STAT6, I would encourage you to do that because that is useful in assessing a solitary fibrous tumor with CD34 as well. There are rare cases which have a variation in the immunohistochemistry, so it's best to do both. And then I've got PCOMA coming up here as well. So PCOMA, again, would be addressed with our muscle markers. And the muscle one here I'm thinking of is SMA. You could add a calponin, which is also a good muscle marker for PCOMA. Remember, Desmond, if positive, maybe just very focal, so not very helpful. But if you're thinking PCOMA, then you want to include your myomelanocytic markers. So you want to use your melanocytic, your true melanocytic markers. Remember, we got S100 and SOX10 for nerve sheath. It's not a true melanocytic marker. It marks up nerve sheath, tumors, and other things as well. But the true melanocytic markers are HMB45, melin A, MITF, PRAME, tyrosinase, those sorts of. So for PCOMA, when I'm doing a screening tool, and I'm glad this was brought up here, is I would do an HMB45, perhaps a melin A, and an actin, and maybe a calponin. So I cover both my myomelanocytic markers. Now, many of you are already wondering, why do I do two markers? And that's been my approach, because you do get variation in staining based on processing, fixation, laboratory techniques, etc., etc. So using two markers when I target a particular differential diagnosis helps me balance the two, and that's just been my practice for many years. So again, I just share with you what I do. I don't say it's right or wrong, but I justify it to my comfort level. Okay, so we've got some pretty decent markers cooking here. I'm gonna cut down to the chase. Okay, so Desmond is diffusely positive, and the GIST markers are negative. CD34 is negative, and obviously we threw in STAT6, so that's negative. Got that out of the way. But both SMA and Desmond are diffusely positive. HMB45 is negative. We did not beg your pardon, uh, uh, do anything for synovial sarcoma. There are good markers for synovial sarcoma. As you know, there are antibodies targeted towards the fusion itself, which is X18, XXX, or SYT, or both the genes, the fusion genes produce a protein which has been done. There's nice papers my young colleague Esther Baranov wrote about when she was at the Brigham, and you can go to AJSP Baranov synovial sarcoma antibody. That paper will come up, and the Brigham uses antibodies to good effect. We have the luxury of having FISH, fluorescent in situ hybridization. So if we're seriously worried about synovial sarcoma, and the respondent mentioned a biphasic because of the glandular component, so I applaud you for that, for thinking of the biphasic, then I would resort to FISH for SYT. Now, with the immunohistochemical panel of diffuse Desmond, diffuse SMA, I would move away from synovial just based on immunohistochemistry. Okay, you could use TLE1, which people have put forward as being supporting synovial, but that is really not very specific. We've seen other tumors come up with TLE1, like MPNST, etc., etc. So don't rely on TLE1 alone. You'd have to resort to molecular or antibodies to these fusion proteins that I talked about. So morphologically, though, that was the immuno and the FISH. Morphologically, though, I agree there are spindle cells and epithelial structures, so biphasic comes into the differential. But in my mind, when I think of synovial, think of a very blue tumor, very hypercellular blue tumor with a lot of overlapping nuclei. Here, just to take you back here, these seem to be pretty decently respecting each other's spaces. The cytoplasm is also very, very pink, very pink. And what I did not say to you earlier on was that the nuclei look cigar-shaped. You all know that the nuclei of smooth muscle is described classically as being cigar-shaped. And I've already shared with you that Desmond and actin are positive, and excuse me, the differential diagnosis of FH leiomyoma has been put forth, and I applaud you there as well, because whenever I see bizarre cells, I did not want to use the word bizarre, I just used atypical. But when I see bizarre cells in the background of smooth muscle cells, then FH leiomyoma is the first thing I want to rule out. And you're familiar with fumarate hydratase, which is an enzyme from the Krebs cycle that's mutated in FH leiomyoma or in hereditary leiomyomatosis. And so that step is lost. And so there's a loss of expression of FH in these tumors. Another marker for FH leiomyoma is 2x or 2 times succinate, which is the step above the fumarate hydratase. And that's increased because in the Krebs cycle, it doesn't progress down. So you can do 2SC as well if you have that. We don't have that. Now, remember that FH leiomyoma does not always mean that the patient has hereditary leiomyomatosis. It could be a sporadic version. So you have to defer or refer the patient to genetic counseling for a germline mutation to rule out hereditary leiomyomatosis, which in itself is a pretty significant disease, because that's autosomal dominant. So you've got to screen the family members. You've got to look for leiomyomas of the skin, cutaneous leiomyomas, and more importantly, you have to rule out or watch these patients for renal cell carcinomas. What type of carcinomas? Well, I like to think of in the old term, I think of the grade 2 or the type 2 papillary renal cell carcinomas, lots of papillary structures, high-grade nuclei, and so they are high-grade. So that's what I like to think about in that regard as well. There's atypical leiomyoma with bizarre nuclei, which is what I think this is, because the FH was intact. So in other words, the FH staining was positive in the nuclei. It's a nuclear stain, remember? And in FH deficient leiomyomas, it's absent. So when we think about these stains that we now use for immunoreactivity, whether it's present or not, like RB1, MMR, the terms you want to use is intact, absent, or loss. Okay? Don't use positive and negative because it's confusing. So you want to say it's intact or loss. So, or deficient or loss. Deficient is also another way of using it. Whatever terms you use, stay with it. So your clinicians get used to it, your surgeons get used to it, and you can stick with that. So I like the suggestion here that is put forth: atypical leiomyoma with bizarre nuclei and endosalpingiosis. Except the endosalpingiosis is typically within, not really within smooth muscle. And so the question there came up was is this endosalpingiosis or is this an adenomyoma? You can debate it. It's both benign. I see there's a note here, and I thank you for that. No, it's not leiomyosarcoma, because remember, when you're thinking of leiomyosarcoma, let me back up a bit. Before I get to the leiomyosarcoma component, and just write LMS here so I don't forget, is that before I get to addressing that, I was convinced that this was of Mullerian origin, in other words, from the GYN tract. And so the question that I would ask you just to think is, how would we prove that? And the way I do it is I do ER, estrogen receptor, which is positive in smooth muscle cells from GYN tract, and WT1. That's Wilms tumor gene 1. That's the N-terminal, not the C-terminal. And you all have that in your laboratory because you use that for serous carcinomas. You use that for mesothelioma as well. So that's the one you want to use here. That's positive in smooth muscle tumors of GYN tract. And that's helpful in that regard. So this was positive for WT1 and was positive for ER. So I was very happy that this was of Mullerian origin, all right? And so in interpreting, if I take this and put it into the GYN tract, what would I call it? That's what I began thinking about. And the name I coined, really literally coined up with extrauterine adenomyoma with bizarre atypia of Mullerian origin. And we Google that, and lo and behold, there were a couple of case reports with the exact heading. And so I was very happy and confident that somebody else in the world had seen this and had called it the same thing. Before I end off with this case, I wanted to address leiomyosarcoma. Now, knowing this is of GYN origin, there are nice papers written by Marco Miettinen, 10, 12 years ago. There's about 4 to 6 papers where he talks about these GYN Mullerian origin smooth muscle tumors and the importance of distinguishing those from soft tissue smooth muscle tumors. Why? Because the criteria are different, which comes back to my addressing Maria question is, we need mitosis and necrosis. Both of those were absent here. There were bizarre atypia. It was very focal. Remember, the atypia and leiomyosarcomas of GYN has to be diffuse, has to be at least moderate to severe, and diffuse. You have necrosis and you have mitotic figures. And mitotic figures, again, must be more than 10 per high power fields, okay? Please don't ask me to convert that to millimeters squared. I'm not too sure. You can ask my friend and ex-fellow Ahmed Lazim, was very familiar with that. He's from Iraq and he's now in Memorial Sloan Kettering. But this is not leiomyosarcoma because it does not have that diffuse atypia, does not have mitosis, and does not have necrosis. So that's the thinking there. Now, just to address more of your questions, I really love your questions. I suppose the focus of necrosis without granulation, what would you call this? So focus of necrosis without granulation means there's an abrupt change between tumor cells. In this case, we're talking about leiomyosarcoma, so smooth muscle cells, an abrupt change and then necrosis. And that necrosis has to show detritus, nuclear debris as well. If there is a hyalinizing granulation type of tissue between those two foci, spindle cells and the necrosis, then I use the word hyalinizing infarction. And I see that in leiomyomas, and I see that in leiomyosarcomas as well. So primarily, you've got to come back to your mitotic figures, necrosis, and atypia for that. Let's see, would Paxate be helpful? No, because Paxate is a marker for both GYN and GU renal cell carcinomas, but it's an epithelial marker. I think of Paxate as being an epithelial marker. Would it be helpful? Yeah, probably yes, to stain up the endosalpingiosis. Here's another focus here as well. A nice example there as well. Probably to stain that up, that should be Paxate positive, but that's endosalpingiosis, not endometriosis. There's no hemosiderin, and I don't think that the stroma really resembles endometrial stromal tumor, which brings another marker if you need to know, is this endometriosis CD10? So that's helpful as well. So I Paxate, I did not do it, but it was just based on the ER and WT1. How can we explain presence of cystic spaces? That's the endosalpingiosis, or that's the adenomyoma. So when you think about adenomyomas in the GYN tract, remember they occur typically in the cervix, smooth muscle, and then these bland, benign glands in that. So like I said, we can debate whether it's endosalpingiosis or just part of the adenomyoma. But they're all great questions. I went for just adenomyoma. Is this a typical pattern? Yeah, I think so. You don't necessarily get those sort of phylloides-like patterns, so you could debate that as well. Remember the phylloides-like that we see in the breast. That's the kind of pattern you want to see in adenosarcoma, right? So you may debate, I want to see that in adenomyoma as well. So it's benign to me and both the components. I was just happy calling it a adenomyoma extrauterine and of Mullerian origin because I had the markers to prove that as well. Was it expressing ER and PR? Yes, it was expressing ER. I did not do an PR. I just did ER and WT1, excuse me, which is positive in the smooth muscle cells, which told me this is of Mullerian origin. All right. So that really is probably the most important takeaway, WT1 and the ER, because when you're looking at pelvic smooth muscle tumors, groin, inguinal, in woman, obviously I'm talking about female genital tract, then you need to establish, is this of Mullerian origin or is it of soft tissue origin? Because your criteria are different for both those, okay? In soft tissues, when we see one mitosis in smooth muscle tumors, we get really concerned. If it's not Mullerian, then, well, I think it is of Mullerian origin, Maria. I think this is extrauterine adenomyoma occurring in the abdominal wall, like you would get endometriosis occurring in the abdominal wall. I do not know the pathways of how this occurs, but I was happy that it has been described in the literature, and I was able to Google it and found at least 2 papers talking about the same thing. So, I think the morphology and the immuno supports that. I was very happy and confident, and the clinicians were happy it was benign. So it was just, follow up and nothing, no other modalities of treatment required. There's one here with a bit of mucinous material in it. Yeah, it's more attenuated. Okay. Any other questions or comments? Can we call it leiomyoma? Yeah, you can do that. I mean, like I said earlier on, Dr. Afzal, that you could use that terminology. I just chose to use an adenomyoma. It was benign, and was very happy that this was atypical as well, or bizarre, if you like. Because if you put this in the GYN tract, that's what you would call it. It's both benign, and I don't think anybody's going to be fussing with you as long as you don't call it malignant or leiomyosarcoma. All right. Thank you for those comments. They've been all exceptionally useful and challenging. If there are no more there, I think the histology of C-section might help her. That's a good question. It's a very good question, because C-section, as you know, sometimes does cause endometrial tissue to result in endometriosis. I couldn't find that history. We did look for that. I wasn't aware that she had a C-section, but that's a good point. We did look for that. Okay, let's see what you think of this one. The histology of, yeah, okay. Could previous biomaker cause seedling? That's a good question. It's a very good question. I guess it could. You know that, particularly in this country, in the US, you're not allowed to use those morcellated systems for myomectomy because, you and I as pathologists find it difficult to interpret those and give accurate diagnoses because they're so morcellated. So this country, that surgical procedure is not allowed, because there have been some cases where leiomyosarcoma was missed in these morcellated myomectomies, and patients presented with disseminated leiomyosarcoma in the abdomen. So as far as I'm aware, that type of surgery is not allowed here. So the answer is yes, it can cause CD. Is focal atypia allowed? Yes, focal atypia is allowed. In fact, when I see focal atypia on low power, then I think of FH. If FH is intact, then I call it bizarre leiomyoma. And I look for mitosis and I look for necrosis as well. So it's a combination of all three factors. But this is the classic picture of FH deficient leiomyoma. This is the classic picture of atypical or bizarre leiomyoma as well, in the absence, obviously, of mitosis and necrosis. The other points of FH deficient leiomyoma is to mention when you read the papers on that, they also talk about the so-called alveolar edema. You see these areas that show edema on low power, and then you can also see intercytoplasmic inclusions, and we see a few of these every year. So those are also quite useful. If you look at the nuclei in FH deficient leiomyoma, they have a nucleolus. This one did not have a nucleolus. This was more the sort of ancient type change because it had the internuclear vacuoles or halos, whatever you want to call it. But there were no nucleoli there. The FH deficient ones typically have nucleoli, and around the nucleoli, you may see a halo. So-called perinucleolar halo is seen as a subset of them. None of them are specific. You can see them in other leiomyomas. Like I said, not even FH deficient means it's a hereditary leiomyomatosis. Okay, so good questions, guys. How about this one? This is another challenging case. So this is a 42-year-old woman, and this is an epidural tumor. I inherited this from my neuropathology colleague, so I'm very happy to share this with you, okay? There was an Italian pathologist who visited us a few years ago. She was a neuropathologist, and she said that the best friend of neuropathology are the sarcoma pathologist. So just share. Why am I sharing that? I don't know. That I got this from neuropathology. Okay. Yeah, so there's an epidural tumor. Not sure which part of the dura. 42 female. And you can see there's a lot of cautery artifact, but this particular section there shows, I think, well-preserved tumor. So I'll stick with that. Maybe just show you the, yeah, there's a lot of cautery artifact. I think there's a lot of cautery artifact here as well. But oh, there's this good tumor here. This is artifactual, so I don't want to waste your time here. These spaces are artifactual. I think what I want to do is just share with you good morphology. So sheets here, just to show you the patterns, sheets and sheets of these pretty uniform, round to ovoid cells. Okay, and even here is pretty decent. I hope you can see this clearly wherever you are in the world. All right, I hope you can see this pretty uniform. And notice it's got a very pink cytoplasm as well, right? Nice pink cytoplasm, respectful of its neighbors, not really adherent, loosely cohesed in some parts. I like glomus tumors come up there. That's a great start, glomus tumor. The only marker for glomus tumor is an SMA. So you're probably ought to rule out all other glomoid lookalikes. That's a good thought. Glomus tumor, it does have a very nice glomoid pattern. And glomus tumor can occur in visceral organs. I've never seen one in the dura. I've seen it in the lung. I've seen it in the stomach. I've seen it in bone. I don't think I've ever seen one in the dura, but glomus is a good start. I'll shoot off with that by telling you that the actin was negative, although that's the only stain you can use, and you need to rule out other things as well. So actin's negative, and I'll leave that at that for this point, but very good thought. I like your nested pattern uniform cells as well. Okay, we are going down the list here now. I've got picoma here as well. And again, I said actin was negative. It's one of my screening tools for picoma. So I'll tell you that was negative. And then Desmond also is negative. So just to get that out of the way for the PICOMA. So, but that's a good thought. I like that PICOMA start there as well. There's a Ewing sarcoma here that's been put in as well. Let me stop and pause just to address. I would do the CD99. Don't get me wrong, Michael. I would do the CD99, but the cytoplasm is not quite wrong, not quite correct for a Ewing sarcoma. It's too pink. I showed you those. Let's go back to let's go back to that area I showed you, because the cytoplasm was pretty decently. It's a thin area here. Here we go. And you can see how pink that cytoplasm is. So glomus is a good thought, but glomus has a very well-defined cytoplasmic border as well, and is really cohesed, just to go back to the suggestion earlier on. So that's a PICOMA is also very good, lacks the vascularity, but you may argue, oh, this could be a sclerosing PICOMA. Fair enough, fair enough. But Ewing sarcoma, just morphologically, I would do a CD99 just to rule that out. That's my typical screening tool whilst I wait for the FISH analysis. But the cytoplasm is very pink here, so I would not expect this to be the classic Ewing sarcoma. But let's do the CD99. If you want to do the EWSR1 based on that, yes, we can do that. So we're doing the FISH for that. And then for the PICOMA, I know I only addressed Acton and Desmond. I did not say anything about the melanocytic markers, but we can do that as well. So we got melanocytic markers cooking, we got EWSR1 cooking, and we've got chordoid meningioma. That's a very good thought. So the chordoid meningioma looks like a chordoma, except it's a meningioma. And maybe some of these cells do look sort of chordoid-like with strands and nests. So okay, we'll keep that in mind, and then we will resort to meningioma markers, and EMA is a good marker for that, and of course PR, progesterone receptor, and then of course SSTR. SSTR is probably the most useful these days. We've got plasma cell neoplasm, again, because of the color of the cytoplasm. Some of them looking a little eccentric, and you could argue some of them looking a little plasmacytoid. So that's a good thought. I like plasma cell neoplasm. I'll tell you right off the bat, I cannot remember whether the CD138 and the actin and the light chains were done. I cannot remember, but that we can come back to that. There's a Desmond here as well. And we did the actin and Desmond, and I've given you that as negative. And then there's neuroendocrine tumor. Of course, the nested pattern does bring in the neuroendocrine story as well. I'm just wondering in that location site whether you'd be thinking metastatic neuroendocrine tumor. So yeah, we're going to throw in the neuroendocrine markers. And again, I share with you my approach and pattern of if I think NET or neuroendocrine tumors, because we occasionally do pick them up in metastatic bone tumors, then I'm doing all three: synaptophysin, chromogranin, and INSM1. So with the epithelial marker, I would do all three. Unfortunately, we do have that as well. So there is a net that follows neuroendocrine, so we address that as well. Are there any rosettes or neurofibrils? Not to my appreciation. I did not see any rosettes that would probably fit into the Ewing's thought that was given earlier on, or if you're thinking one of the primitive neural tumors as well. Here's another. This is a little darker and thicker, so not seeing very good morphology, but it does show you the pattern very well. They're not plasma cells. I'll get that out of the way. It's not plasma cells. Chordoid meningioma was given, and SSTR was negative. I didn't finish that sentence. There's a chordoma here as well. So, if this is base of skull, sure, you'd be thinking of chordoma, but not the conventional classic one. If anything, you may raise the possibility of poorly differentiated chordoma. Those typically occur in the thoracic spine and the INI1 deficient, but you still need the brachyuria. Brachyuria is negative here as well. All right. Plasmacytoma, we've done the plasma cell markers. And then, of course, rhabdomyosarcoma has to come into that. Desmond was mentioned. I said it was negative, and I said that the actin was also negative. Chordoma is coming up again, and chordoma again, the brachyuria was negative. This came to me with my neuropathology colleagues having done that. So I'm able to share with you that brachy was negative, and so was SSTR, that's somatostatin receptor, which is for meningioma. Lymphoma low grade, a little bit of too much cytoplasm. I think plasma cell was probably a better option there. Myepithelioma, yeah, soft tissue myepithelioma is an excellent thought. This happens to be keratin, as I see that it's keratin negative. Remember, you can always do EMA for myepithelioma because you always juggling the myo with the epithelial. So don't forget EMA. It's a useful marker for myepithelioma, along with any of your favorite keratins as well. So this is negative for keratin, negative for EMA. So hemangiopericytoma is given in the context of this being a dural lesion. We don't use that term anymore. So the current terminology for hemangiopericytoma of the meninges is in fact SFT, salty fibrous tumor, which we addressed in the previous discussion. So CD34 and STAT6, just to rule that out. Yeah, they can be cellular. And if you think about it, I always say to my trainees, fellows, and residents, if you think about something, just do the stain. Particularly in odd sites with such much cautery artifact, there's no harm in doing that. So, although it doesn't strike me as being a salty fibrous tumor, the lack of the vascularity, the lack of the patternless pattern, the hyalinized vessels, the alternating hypercellular, etc., etc. But if you thought about it and if you did it and we were working together, I wouldn't be too upset. Myepithelioma, we just talked about that. Keratin's EMA negative, SMA, Desmond negative. I also like calponin for myepithelioma. I use it for PCOMA as well. So it's also useful in that respect as well. Melanocytoma. Okay, so we've got HMB cooking and we've got EWSR1 cooking. Melanocytoma. I've made a diagnosis of a cutaneous melanocytoma, and I know that these do occur on the meninges as well. So we'll have to wait for the melanocytic markers. Here we go, pseudoendocrine sarcoma, all the way from my good old friend Chris Fletcher. Those are usually paraspinal. They look like neuroendocrine, which this does, nested neuroendocrine. We had 3-4 people say NET neuroendocrine. So that would be a very, very, very good thought, except it's negative for neuroendocrine markers, negative for epithelial markers. And the only marker that is positive for is beta-catenin. So keep beta-catenin. Remember, it has to be a nuclear stain because the beta-catenin is transferred because of the mutation from the membrane through to the nucleus. And so it has to be a nuclear, like in pseudopapillary tumors of the pancreas as well. So they're always, even in fibromatosis, you're always looking for nuclear stain for beta-catenin. Ependymoma, we did the EMA there. We didn't include a GFAP, but my very astute neuropathology colleagues did. And so it was a negative for ependymoma. They can occur outside of the neural axis. They can occur in front of the sacrum, behind the sacrum, the buttock. So yeah, being aware of that as well. Melanoma. Okay, we have another melanoma here. We have PCOMA. We have Ewing as well. And we have got melanoma markers still cooking. Okay, I promised you HMB45 melanA. That's going to be coming. Looks too epithelioid. Cytokeratin negative. Yes, Maria, it's negative. It does look epithelioid. And this can be soft tissue, ependymoma. Yeah, that's a question, Michael. That is a question. That's what we have to deal with. Ooh, Nelson. I think this is the Nelson from Botswana, I think. I may be wrong. He's a senior resident, just come back from his senior training. Now, he's making a very good suggestion. Clear cell sarcoma or soft tissue. Remember, I kept away melanocytic markers. And remember, I kept away EWSR1. So you're spot on there, Nelson. Yeah, this is a clear cell sarcoma occurring in the dura. I've never seen one in that location. But it was also SOX10 positive, which, as you know, can be S100, SOX10, and of course, melanocytic markers positive as well. So, you know, I'm going to share with you something that I think everybody in the whole world wish they had. Our neuropathologists have the luxury of sending each and every tumor for next-gen sequencing, right? Both RNA, DNA, and fusion panels, every tumor, right? And so a week or two later, this came back with EWSR1, and you all know the partner to clear cell sarcoma because I've given you the diagnosis, which is CREB1. And so they asked me for what you call a blessing. And lo and behold, the marker panel was full house. The immuno was full house. And the fish of, no, this wasn't fish. This was sequencing because they got both fusion partners. So I immediately got myself a recut to share with you. Yeah, this is a clear cell sarcoma. And as you know, was first described by the great Dr. Enzinger, what, 40, 50 years ago. He called these malignant melanoma of soft parts. I always like to give you the morphological historical terms because that tells you what this immunohistochemistry is. Melanoma, right? So you're going to have all of your melanocytic markers in varying degrees positive as well. And of course, you know, Dr. Enzinger did not know that there was a fusion. And of course, years later, when it showed that this is a distinct entity with this fusion, it became, you know, a tribute to his morphological excellence, if I can put it that way. Morphology didn't look like any meaning neuroendocrine. Is this a male patient? Any history of prior cancer? Let's see. No, female, 42 female. Some alveolar pattern was also there as well. Yeah, the alveolar pattern was there. We talked about alveolar rhabdomyosarcoma, and then clear cell sarcoma, as you know, typically has this nested pattern. They can sometimes be spindled, and this pattern is very reminiscent of that, along with all the other tumors, like you said, metastatic carcinoma, alveolar rhabdomyosarcoma, NET, pseudoendocrine sarcoma, the entire list that you guys have been going through so beautifully, including myepithelioma. So in our hands, it would have required a real deep investigation with our immunohistochemistry and then embarking on appropriate molecular analyses. Of course, our neuropathologists have the luxury of send it off for next-gen sequencing, which has a panel of over 400 genes, comes back beautifully with the answer. All right. Any questions or comments? This is a rare location for a rare tumor as well. So looking at it again, there's some pigment in the background. There's some astute. Who is this? Michael. Yes, you are correct, Michael. That's a very good question. This pigment is refractile, Michael. It's refractile and much more granular. So I interpreted this to be hemosiderin, just from blood and hemosiderin. Is that a clue? Well, when you go back to Dr. Enzinger's paper and you go back to the big, I'm looking up at my Enzinger and Weiss, and I've got a very old edition. If you go back here, they quote this book, and if you look at that, you'll see that only, I may be wrong here, and I'm probably going to ask Professor Govender to correct me. I think only about 50% can have pigment, very, very focal. So you can look for it. It may be helpful, but again, it's very focal. And even in those days, the clear cell sarcoma came from glycogen. That's why it was clear. This one looks pink. This is not even clear. So we now know that they can be clear, they can be pink, and they can be spindled as the morphological spectrum expands with the molecular support. We know that they're all the same tumor based on, again, evidence based on how they behave as well. So yeah, this is just a nice, unusual. Is that pigment a clue? Yeah, I wouldn't use it, as a clue. I think I would just hone into the cells and try and figure out. And if you thought of PICOMA, did your HMB, that'll help you. Thought of melanoma, you did HMB, that may help you as well. So, there's various ways of getting to that by just using your immunohistochemistry and then nailing it down. And, I'm sorry, but in developing countries, you don't necessarily have next-gen sequencing of fish, and this is always a problem. And most of these books and publications are written in developed worlds, and so molecular becomes part of it. What's going to happen to the developing world? I was thinking about that question this morning because I was looking at the current episode of Modern Pathology. There's a nice paper. If you get Modern Pathology, there's a current paper looking at the role of, I'm going to see, I was trying to print that paper out, the role of the WHO classification in developing countries because of all the evolving molecular connotations that we have. I think that's what that paper addresses. And I thought that that was fascinating. I haven't read the paper, but I'm just sharing it with you online. I don't think I printed it. I'm sorry. I'll give you the exact reference. But it's in September, this issue. If you get, if you get the Modern Pathology, or even if you go online, that will help you in that regard as well. So, and I don't know how to address that really. I do visit countries in Africa as well, and we're constantly talking about that. All right. Oh, there we go. Here we go. Yes, yes, Dr. Wang. That's very good. I'm glad you brought up that differential diagnosis, because remember that also the group, the family group of EWSR1. Remember, EWSR1 belongs to the FET group. So the FET stands for FUS, E is the Ewings, and T is the TRAF15. So FET is a good family gene that's used. But remember that both FUS and EWSR1 belong to that. Because if you use only FISH for EWSR1, you've got to think about FUS as well as an alternative if that does not come back rearranged. And then, of course, CREB is the CREB family of genes, which, as you know, has CREB1, CREM, CREM, and ATF. That group of FET, FET, CREB is a huge family. When I last checked, there's something like 8 tumors in that. Okay, so you can look at the literature over the last 8-10 years, and you'll see that this family has just been expanding. So clear cell sarcoma was the seminal tumor with that fusion gene. And then they describe it in the GI tract. They call it GNET, gastrointestinal neuroectodermal tumor. But it's the same thing, although the immunohistochemistry does not have the melanocytic markers. And then, of course, there's other tumors like the primary pulmonary myxoid tumor, the simple angiomatoid FH. That's the same group of tumors. Here, Dr. Wang mentions the intracranial mesenchymal tumor that belongs to the same group, that fell into the same group. And there's also a testicular tumor with sex cord stromal and inflammatory like changes that belongs to this group. I'm just overlooking one or two. Oh, of course, hyalinizing clear cell carcinoma. So always think outside of mesenchymal tumors. But you know the jaw, I beg your pardon, the salivary gland tumors, hyalinizing clear cell carcinoma has the same family of fusion genes as well. There's one or two more that escapes me. Oh, and you can also get extra-intestinal GNETs, which occur outside of the GI tract. And the only way you're going to distinguish those from this classic clear cell sarcoma is by immunohistochemistry, because the absence of the melanocytic markers is what helps you with that. But the genetic fusions are the same. So it's just fascinating. And Dr. Wang brought up that question, but I just find this a fascinating group of tumors. And so thank you for bringing that, because it brings the discussion up for the FET CREB family of tumors. So in the old days, we used to write essays when we wrote the board. That's a great long question. As an examiner, I probably would put it in for a part 2 candidate very comfortably, knowing that the last 8 to 10 years has covered most of these tumors. So it's a nice essay just to write about the different fusions, the morphologies, and the immunohistochemistry. Sandhya, can you please say again, what was marked? Oh, so this was positive for HMB45, Melin A, and also SOX10 as well. So there you go. You had three markers that were positive. Maria Faraz, what is your question there? This one is not expressing as yeah. Well, you do get variations of this. This is HMB45 pos and SOX10 pos. But as long as you got, in my book, if I've got at least 2-3 melanocytic markers, I'm very happy to go with along with fusion confirmation. Please, can you recommend any paper reviewing this family of tumors with a concise discussion of all the Michael, is there an easy I'm just trying to think. I can look, and then the next time we meet, I'll try and put that up for you. Top of my head, is there a good review of the FET Kreb family of tumors? There are. I just cannot put a journal or a review for you at the top of my head. I mean, Michael, if you go to let me give you another backdoor route. If you go to modern pathology, you punch in modern pathology, you punch in Andrew Thorpe, and you punch in extra GI, gastrointestinal, GNET, GINET. That's in modern pathology. I think it was 23 or 24. In his discussion, he goes through all of these tumors, and there you'll find he goes through all of this entire family. So that's a nice sort of segue to bringing up all these tumors. And like I said, if I was still an examiner from the old days, I probably would put that into an exam. But you guys write short questions and multiple choice questions, which is nice. I don't have a problem with that. Just keeping up with the times. Okay, any other questions or comments? We've got 5 minutes, and I'm tempted to perhaps just do one more case if I can find it. 39139. Oh, there it is. Okay, this is fairly straightforward. I know nothing is straightforward, isn't it? But this is a parotid mass, parotid gland, 69, female, and well circumscribed on low power, fairly well circumscribed. But you will see here, there's this area, and I know you all know the answer here. It's myxoid, strands, cords. There's no epithelial structures here. Little nests of cells. Very similar to what we just saw, isn't it? Pink. Okay, and this is in the parotid gland. Here you go. Nice, beautiful little cords and nests here as well. All right. So there's that component. And then right next door, I'm trying to find, yeah, so here you can probably see the links here where you see these nests and islands, these very uniform looking cells, myxoid, myxohyaline background, and then that merges here into this component. This is what I want to show you here. Okay. Again, similar type of cells, but a little more sclerotic here, a little more sclerotic, and then going outside of the capsule. So clearly breaking through the capsule here. All right, this back down low power. Okay, there's a defect here. And let's follow the capsule. Follow the capsule. And here you can see this just breaking out here. So same tumor breaking out and giving rise to this component. So there we go, myopithelial neoplasm. I love that. And that's what this is. This is myoepithelioma, just based on the matrix, mesenchymal type matrix. And then the cords and strands, and we talked about the myopithelial markers earlier. S100 is the bridge between the epithelial, EMA keratin, and the myo, actin and calponin. P63 is also a good marker. GFAP is also a good marker. And there, Michael, you got it there. Nkwekwe, that's great. Great, there you go. So myopithelial carcinoma arising in a myopithelial rich. Okay, you want to use pleomorphic adenoma. Are there any glands, ducts here? All right, you can justify that. That's fine. That's fine. This does have some possible glands and ducts. But yeah, that's with low grade. It's all low grade. Just a nice little, myopithelial carcinoma creeping out from this myopithelioma, or like you say, myopithelial rich pleomorphic adenoma. There was a paper about 2018, 2019 in American Journal of FRCPath from the Memorial Sloan Kettering, where they talk about these pleomorphic adenomas with myopithelial rich and when and how to call them myepithelial carcinomas. They followed a small series, and they found that tumors that were called myepithelial rich and tumors that had more lobulated appearance and more monotonous cells did recur, and their not argument, but their debate there was, could we call these myepithelial carcinomas de novo? Interesting question. Can this be clear cell carcinoma X pleomorphic adenoma? Well, this marked up. That's a good question, Maria, because I didn't go into it, but this marked up as the myepithelial cells in the myxoid area. So it clearly had, both the S100, the myo, and the epithelial components positive. Clear cell carcinoma can have P63, can have glycogen. Of course, you'd need the fusion to confirm it if you have that as well. And does have a hyalinized. I know you went for this pattern here and asked the question, could this be a clear cell hyalinizing? But this does have the markers of myepithelial differentiation, so that helps with that. Somebody's posted, some kind person here has posted a PubMed. I don't know if that's the question that Michael asked earlier, a paper that has everything in it. Is that it? I don't want to go in there now because I'm online, but I want to thank you all for joining me. I want to thank Ava for again setting this up. I haven't set a time yet, but Ava and I will work on another time for another conference, and I look forward to all of you joining me. And I loved this past hour, and I enjoyed being with you. So thank you very much. Thank you very, very much.